Okay, everyone. We are instructed to be strict on time. That means both the moderators and the speakers. So there is not going to be a long, lengthy introduction of the speakers. You can find only in the book. But the first two presentations are, I would say, by two icons in the world of LSD. And Professor Tomatsu will talk about AV gene therapy and clinical trials for MPS IIA. Mokito, you have done so much for this, and we are looking forward to hearing you. Thank you.
Thank you for introduction. I want to talk about today AV gene therapy and the clinical trial for MPS IIA. This is disclosure. I have a lot of disclosure, but most of them from NIH. And specifically, we have a quite a large grant for sponsorship from NIH, Natural History Program for molecule MPS IIA. That's quite important for us. So this is a round object. You can see a very simple one. So before I'm going to the my presentation, unfortunately, you know that Bill Fry, my mentor in the United States, passed away in May 31 this year. I hope and also Bill Fry, I prayed for them. Yeah, he's a pioneer in our field in LSD. Everybody knows. Okay, so our research field is a very small area, mucopolysaccharidosis, 1 out of 25,000 births, but particularly MPS IIA is a 250,000 births, 1 out of 250,000. Point is that this is a skeletal dysplasia systemically and then very progressive. So where we don't have any solution yet to cure. So this is my research history since I came from Japan 1995. So then before that, 12 years I studied these disorders. And then initially I went to St. Louis University with Bill Fry. And then switched gear to 11. I'm now here at Nemours Children's Health. So there are a group of discussion today, but this is where we are. And then we are conducting natural history program and a variety of gene therapy and enzyme repair therapy right now to impact the bone. That's where we are right now. Kind of a 40 years history, personal history involving this disorder. So molecule A is quite unique again because of skeletal dysplasia. If you see these patients, at first nothing appear normal, but with age you can see that quite a prominent chest and also laxity of joint and also cervical, spinal spine is very flexible, laxity. And then also no knee is very prominent. And finally, teenagers, airway narrowing, trachea problem is happening. So most patients die over 20 to 30 years old. 2/3 are coming by the respiratory issues. 1/3 is die of heart disease. So I don't want to talk detail about the molecule itself, but essence is that imbalance of growth. That's the most critical issue for molecule. So growth stand by 8 to 9 years old. The final height is quite limited, like 110 centimeter for women. And then 117 centimeter for boys. So this is one of the fatal factor for the molecule. as I mentioned, tracheal obstruction. As you can see here, in teenager, over 90% of patients have narrowing trachea. And then in this regard, this patient, 95% of this location is narrowed in trachea. So then if you can see that here, over the top of the trachea vessel, anominated vessel is over the top. So therefore, trachea is compressed. That happens. If we see this one is, since it's life-threatening, we need to do surgical operation. Again, trouble is that trachea is still growing, but bone is stopped much earlier. Then vessel is still growing. So inside our body, visceral organs, others are growing, but growth is stopped. So because of that, we call it imbalance of growth. That's a problem for molecule. So another big issue, as my colleague Bechu mentioned, it's avascular. That's quite trouble to cure the disease. So then, how can we reach the bone? This is the most trouble in growth plate region. Unfortunately, until now, nobody can, answer this question. Again, because of avascular. Without a vessel, we cannot deliver the drug, especially in a deep area. That's where we are. So we tried a number of therapies so far by using our molecule A mouse model, which is ERT, HSCT, or combination, or AAV, or lentiviral vector, which Bechu mentioned, or CRISPR-Cas9, gene editing, etc. But clinically, most impact one is actually orthopedic therapy, surgical intervention, and also tracheal reconstruction surgery. That's saving a lot of lives and also quality of life at this moment. So we started kind of consortium with molecule families. This is the first conference, though, almost 2012. Then we come together, cooperating, and then molecule family made a lot of effort to give us the funds for molecule research. We highly appreciate the effort, but still, again, no treatment is effective for MPS OA, as you are aware, although ERT or HSCT is available in clinic. So to improve bone pathology MPS OA is quite a challenge, but we are proposing various AAV vectors in this presentation. So Dr. Khan, our colleague, and also others studied AAV gene therapy. And then we had a number of vectors prepared, especially promoter portion we changed to provide efficient enzyme into the bone. We tried. So study design is very simple. We started 4 weeks old or newborn. Then 16 weeks old, we sacrifice the mice. That's standard. But then we check the variety of metabolic points, and also micro CT or others as an indicator, other biomarkers to check. And this is one of the panel showing a variety of vectors, AAV vectors here can achieve supraphysiological level over the course until 16 weeks when we infuse the enzyme, infuse the AAV vector at 4 weeks old, or a supraphysiological level. And then some of the vector, as you can see that, especially important in the bone. So you can see that enzyme activity in bone, several vectors. That you can see that, even over wild type level. Then another important thing is that whenever we created a vector, every vector, keratan sulfate, which is the substrate, most important accumulated substrate in molecule A. This is untreated mice. But other whatever treated mice, variety of every vector, it's become normalized in blood KS level. Same thing true about especially bone KS. Panel C, you can see that most of every vector it's wild type level. That you can see that. And compared to ERT mice, almost all every vector can see that more impact in terms of humanous bone KS level in every vector. So how about pathology? We expected if we see this case is normalized in bone, maybe pathology could be improved more. But however, this is a wild type and this is untreated. It's untreated one. It's very disorganized and vascularized cartilage cell. When we see the whatever AV vector treated, mouse in growth plate lesion, still a partial correction. It's not complete at all. That's we see. So therefore, we may think enzyme cannot penetrate into growth plate. So therefore, we need another factor to improve the growth plate. So one of the colleagues, PhD candidate, now doctor, tried, it's called two growth associated gene therapy. This is related to the we call it C-type nucleic peptide, CNP. It's a kind of a growth promotion factor, promoting factor. So we did a similar AV vector as I described, and then after treated 16 weeks, so you can see that very interestingly, even CNP only, surprisingly, bone case is normalized, and also growth plate lesion is organized, and then elongated actually compared to even wild type. That's what we see. And then correction of bone pathology also happened with CNP plus GALs. You can see that compared to wild type or untreated, growth rate lesion is much elongated, and also vascularization is quite less. That happened. And another important aspect is that since when we treated by AAV gene therapy, always gene product, we see immune response. So we want to avoid gene product immune tolerable. So Alessandra, PhD candidate, also tried to AAV9 gene therapy with, we call it oral administration of peptide of GALs, epitope. So this is what she did. We studied, oral immune therapy by epitope, 3 epitope here at newborn, and then up to 20 days, every other day, oral intake of epitope. Then we studied gene therapy, AAV gene therapy, and then we followed up 32 weeks. So what's happened is that just one panel showing here is that immune tolerant mice by epitope did not have any antibody from beginning to 32 weeks, and also enzyme activity is much more than non-immune tolerant mice. That's we could see that. So this is the impact of immune tolerance. That's what we see here. And also, starting as early as possible is, of course, we see better. So therefore, currently, what we are working on fetal therapy via AAV vector delivered with, some, transplacental FC therapy. So fetal therapy is why it's required. This is a long time ago, over 40 years. Michael Beck showed even fetus, 16 to 18 weeks, there is a bunch of accumulation in cartilage. That's showing here. So therefore, we tried to transplacental strategy. So after AAV gene therapy in pregnant mice, after birth, so you can see that all fetus, you can see a color EGF expression, strong expression, which is we are very encouraging. Maybe this kind of therapy can apply to fetus in future, not right now, of course, but this is what we are thinking. So in summary, our batch of AAV gene therapy, we see the great, not complete remission, but at least a partial remission of bone pathology. So therefore, we applied to the clinical trial grant. So this clinical trial grant is organized by a non-profit organization, Foundation of NIH. This is what it is. So two PI, Dr. McKenzie, orthopedic doctor, and myself, applied to this grant. So then, it's called, Bespoke Gene Therapy Consortium is organized for this grant application. So object of this consortium, PGTC, is that to make a playbook of AAV gene therapy, accelerate to get approval of AAV gene therapy for rare disorder. That's what it is. And then, surprisingly, 10 NIH institutes and also a number of pharmaceutical companies, as well as family association, rare disease association, joined this program. They raised up over $100 million for this project to make, again, breakthrough for AAV gene therapy for rare disorders. So this is a disease selection process. 2021, they started recruiting the proposal. So 62 proposal is found out. Then after that, 14 selected at the beginning, and then finally, final selection, 8 disorders were selected. So this is a selective disorders. So 2 systemic diseases, including molecule A and other ocular and also neuro degenerative. That's you can see that. In lysosomal storage disorders, MSD and molecule are selected in this proposal. So this is a current calendar of clinical trial of molecule A with AAV gene vectors. So we already open designation is approved. We are now making the clinical trial protocol in the middle. So I want to get help here. Definitely how to select the patients. We have over 120 patients in clinic for molecule. I think world largest population in one hospital for sure. But still, I need how to select a patient. That's quite important. So we need maybe your help or AI-driven, protocol as well. That's quite important to avoid any trouble. And also, we want to select definitely minimize immune response patients. That's our goal right now. That's why I asked some question maybe during this meeting. So this is our current lab members. And also, we are very happy to always help foundation and the family's support. Thank you very much. Appreciate that.
Thank you very much. Thank you very much. Maybe Ryan and others will give you tips later how to select the patient. And now I guess I'm inviting Alessandra Dazzo. We thought she's another icon in LSDs. And I guess I need some help to put her on the screen. Alessandra, welcome.
Good morning to all participants. I would like to start by thanking the organizers for their kind invitation. I'm very pleased to take part in this meeting, even if only in a virtual setting. The subject of today's talk is sialidosis. I will discuss the mechanism of disease pathogenesis and the implementation of therapeutic modalities in animal models. But before I start, I need to go through some obligatory slides. I have no relevant financial relationship with ineligible companies to disclose. The main learning objectives are to recognize and define the main clinical features of sialidosis, to discuss the importance of faithful models to study disease pathogenesis and to implement therapeutic modalities, and last but not least, to illustrate the importance of lysosomal enzymes, in particular Neu1, in controlling basic physiological processes important for cell and tissue homeostasis. The participants are encouraged to use this link to help the organizer evaluate the program and claim continuing education credit. So, sialidosis is a prototypical lysosomal storage disease belonging to the glycoproteinosis subgroup. The disease is caused by deficiency of an essential enzyme, the lysosomal sialidase neuraminidase 1 or Neu1. It is inherited as an autosomal recessive trait, Neu1 being on chromosome 6. Often affected children are compound heterozygous for two allelic variants, which complicate the establishment of a clear genotype-phenotype correlation. The parents are typically unaffected carrier. The incidence of the disease in the population is extremely low. Fewer than a few hundred cases have been reported in the literature. Many of the patients have been described across different ethnic groups, but some clustering of cases occurs in specific population, especially in Italy and in Japan. Sialidosis patients are generally classified into two main forms, clinical forms. Type 1, also known as macular cherry red spot myoclonus syndrome, is the late onset attenuated form of the disease, often difficult to diagnose because of similarity of the symptoms with other clinical conditions. There is a very poor correlation between type of mutation and clinical severity, and it's important to keep in mind that genetic background and lifestyle may influence the clinical course of the disease. The patients have between 1 and 5% residual Neu1 activity and, of course, sialylated oligosaccharides in their urine. Type 2, on the other hand, is the early onset severe type of sialidosis. Again, patients have a poor correlation between type of mutation and their clinical severity, have less than 1% residual Neu1 activity, and of course, sialylated compounds in the urine. To go a little more in details into the clinical symptoms, type 1 patients present with symptoms between adolescence and adulthood, although the onset vary greatly. Key symptoms are visual impairment, myoclonus, ataxia and seizures, gait disturbances, and generally mild or completely absent cognitive impairment and long survival. Type 2, on the other hand, is subdivided in congenital, the more severe form, and infantile juvenile. The congenital form may present as hydrops fetalis in newborns and can lead to stillbirth or survival for only a few months. Key symptoms for type 2 sialidosis are coarse facial features, growth retardation, organomegaly, muscle weakness, hearing loss, and of course intellectual disability and myoclonus epilepsy, as well as ataxia and tremor. The diagnosis of the disease relies on accurate enzyme assay and mutation analysis. Key diagnostic hallmarks of sialidosis are oligosacchariduria, as already mentioned, bilateral macular cherry red spot, skeletal abnormalities, and neurological findings, in particular myoclonic epilepsy. The genetic mutations are scattered throughout the Neu1 gene. There is not a particular mutation hotspot. Most of them are missense mutations, changing only one amino acid. Only a few splice variant and nonsense mutations have been described in the literature. Neu1 protein, as I said, is an essential enzyme. It functions in complex with other two lysosomal hydrolases, namely the protective protein cathepsin A, one of the lysosomal cathepsin, also called PPCA, and the lysosomal glycosidase beta-galactosidase. Combined or single deficiency of these three enzymes leads to two distinct lysosomal storage diseases. Importantly to remind is that Neu1 need to associate in particular with PPCA in order to maintain its enzymatic activity and stability in lysosome. The physiological function of Neu1 is to target the sialic acid containing glycoproteins in particular, but also glycolipids. Neu1 cleaves this sialic acid from these substrates, initiating their sequential degradation and generating a pool of free sialic acid in lysosomes. Deficiency of Neu1 causes accumulation of these substrates that retain their sialic acids, thereby impacting their biochemical properties and function, and in turn, whatever downstream pathway that individual substrates may control. In order to study disease pathogenesis, we have generated an animal model of sialidosis that recapitulates the severe type 2 form of the disease. Like the patients, they have growth retardation, they die early, they develop systemic conditions affecting most of the visceral organs, but also the connective tissue, muscle, cartilage, and bone. And they develop a severe and progressive CNS pathology, primarily affecting the limbic system. The histopathology of sialidosis is typical in these mice, is typical of a lysosomal storage diseases with vacuolated balloon cells in all the visceral organs, the bone, as well as the central and peripheral nervous system. For studying disease pathogenesis, we actually focus on pathological signs that are well characterized and described in patients. And these include neurological symptoms, splenomegaly, oligosacchariduria, and myoclonus. The scope of this study has been to further our understanding of disease pathogenesis in order to inform on possible successful or alternative therapeutic modalities, and of course generating readouts of therapeutic efficacy in preclinical work. In the course of this study, we stumbled upon an important function of Neu1 as negative regulator of lysosomal exocytosis. Lysosomal exocytosis is a ubiquitous process that all cells use to replenish or repair their plasma membrane. It's a calcium-dependent process that entails the recruitment of a group of lysosomes along the cytoskeletal network to the plasma membrane, where they dock prior to fusing with the plasma membrane and releasing their content extracellularly. The docking step of this pathway is mediated by an important lysosomal protein, LAMP1. LAMP1 is actually a natural substrate of Neu1. When the enzyme is missing, LAMP1 remains hyalinated, having extended half-life, and this result in an increased number of lysosomes that align along the plasma membrane of cells. This is a fibroblast, ready to fuse with the plasma membrane and release their content extracellularly. The end result is excessive release of active enzymes extracellularly, as well as nanoparticles like in the form of exosomes that may propagate pathological signals. Based on these results, we started to apply this paradigm to explain some of the pathological manifestation characteristic of the disease, and we started with splenomegaly. The mice develop a time-dependent enlargement of the spleen that is coupled to a loss of bone marrow progenitor from the bone marrow niche and mobilization of this progenitor into the peripheral blood and eventually the spleen. This phenomenon is due to an abnormal and precocious degradation of an important cell adhesion molecule, VCAM1, on the bone marrow stromal cells that is essential for the retention of bone marrow progenitor cells into the bone niche. The abnormal and premature degradation of VCAM1 is caused by an abnormal and excessive release extracellularly of active cathepsin G and neutrophil elastase, two serine proteases that are responsible for the turnover and degradation of VCAM1. Having seen the increase of cathepsin G and neutrophil elastase, we also tested other lysosomal hydrolases, and all of them turned out to be present in larger amount and active extracellularly. So overall, there is excessive release of lysosomal content in the bone marrow extracellular, in the bone marrow niche. The end results can be schematized as following. The Neu1 plus bone niche has a low level of basal lysosomal exocytosis and an excess of serine protease inhibitors that keep serine proteases in check, and therefore progenitor cells can be retained in the bone marrow niche. In contrast, Neu1 bone niche release in the bone niche release excessive amount of active proteases, in particular serine proteases, that eventually inhibit the serine or diminish the number of active serine protease inhibitors. And of course, the end result is abnormal degradation of VCAM1 and loss of bone marrow retention. So Neu1 deficiency affected the bone marrow niche microenvironment, leading to extramedullary hematopoiesis in the spleen, explaining, at least in part, splenomegaly. A similar paradigm is occurring in the muscle. In the muscle, there is an enormous expansion of the connective tissue, as seen in these slides. Neu1 fibroblasts behave as active fibroblasts or myofibroblasts. They are proliferative, migratory. They synthesize and deposit a large amount of collagen upregulate metalloproteases, express epithelial as well as mesenchymal markers, and release excessive amount of lysosomal proteases, as well as exosomes, which are filled with signaling molecules that are migratory and fibrotic, like TGF-beta and Win3 or Win5. The end result is a massive fibrosis. This expanded connective tissue eventually invade the muscle fiber, fragmenting them, and eventually they degenerate, explaining the phenotype seen in children of muscle weakness or muscle atrophy. In the brain, Neu1 mice develop a progressive AD-like, Alzheimer's disease-like amyloidosis, in particular in the hippocampus, where neurons start to accumulate APP, or amyloid precursor protein, in Pompe, so in lysosome, at 1 month of age, and eventually deposit large aggregates of APP positive aggregates in the extracellular space, especially in the hippocampal region and the dentate gyrus. We found that Neu1 is actually, or rather APP, is actually a natural substrate, again, a natural substrate of Neu1. In absence of the enzyme, APP remains ciliated and accumulate both at the plasma membrane as well as, and most importantly, in lysosomes, where it is abnormally processed into A-beta toxic peptides, including A-beta 42, that eventually is released in abnormal amount in the cerebrospinal fluid, of course, amplifying the disease phenotype. So this particular phenomenon is coupled to and accompanied by a massive neuroinflammatory response. The mice present with extensive microgliosis, with increased number of microglia that assume a amoeboid active phenotype. By gene expression analysis, we actually identify TREM2, an important receptor molecule in microglia that turned out again to be a substrate of Neu1. This receptor that works with its adaptor protein DAP12 is important for a variety of pathways and processes in microglia, including migration, A-beta clearance, intracellular signaling, cytokine production, and most importantly, phagocytosis. In absence of Neu1, TREM2 remains ciliated, and as it is the case for APP, accumulate in lysosomes. And this phenomenon is accompanied by an abnormal release of high concentration of cytokines in the Neu1 brain, and in contrast, a very defective phagocytic capacity of these cells towards molecules like, for instance, A-beta 42. So in general, what is happening is that TREM2 remains ciliated, accumulating lysosome, and the plasma membrane is cleaved in two very potent signaling molecules, the soluble TREM2 and TREM2 CTF, C-terminal fragment, that propagate a pro-inflammatory signal, leading to massive neuroinflammation in these mice. So following this paradigm, in loss of Neu1 and increased lysosomal exocytosis, so excessive lysosomal exocytosis can be really put at the basis of at least some of the pathogenic manifestation in sialidosis, but could also contribute to disease outcome in other adult conditions, including Alzheimer's disease and fibrosis. This discovery offered new therapeutic options for the treatment of LSDs and also the possibility to exploit lysosomal enzymes therapeutically for more common adult conditions. Now, where we stand on therapy for sialidosis. For this, I draw your attention again to the sialidosis type 2 form of the disease, the normosomatic form. These patients are more numerous. They live a normal life until diagnosed, mostly by skilled ophthalmologists. More than 30 patients have been referred to my lab, and some of these patients are participating to a study group at the National Institute of Health. We have generated a model of sialidosis type 1 that carry one of the mutations found in patients with sialidosis type 1, the V54M mutation. These mice are fertile, have a normal size. They have absence of splenomegaly as well as EMH, and they have a normal lifespan. But of course, they have a very low residual Neu1 activity. So we have experimented with the therapy that is based on for these mice, that is based on the idea that provided the increased amount of available PPCA to these mice, would somewhat increase the residual enzyme activity in these mice and ameliorate the disease condition. So this turned out to be the case. We treated these mice with an AAV vector expressing PPCA exclusively. These mice have an increased Neu1 activity in visceral organs, improved tissue morphology. So obviously the chaperone activity of PPCA does function in this case. PPCA is, as you notice, scattered throughout. Expression is seen in all main visceral organs as well as the muscle. And and of course, high level of Neu1 activity can be measured in different organs of these treated mice. We have also experimented with unconventional therapy for sialidosis, exploiting the capacity of specific FDA-approved drugs that are approved for other conditions, the capacity of these drugs to actually increase Neu1 activity and gene expression. So beside the PPCA, we actually experimented with HDAC inhibitors, tangenil and betaine, both in vitro as well as in vivo. And the results were actually quite remarkable because we managed to increase Neu1 activity in patients' fibroblasts as well as in peripheral blood cells of the treated mouse models. Last but not least is the therapy that most likely is the method of choice for the treatment of sialidosis and is AAV-mediated in vivo gene therapy. We have obviously did a preclinical assessment of this approach using two AAV vectors expressing Neu1 as well as PPCA. The results were quite remarkable. The therapy was very effective in treating systemic organs as well as the neuropathology, in particular neuroinflammation. The mice have increased Neu1 activity, improved tissue morphology, and reduced inflammation. The expression of Neu1 is present throughout different organs, as well as muscle, as well as brain, by the way, muscle and heart. And the therapy results in an improved gross morphology of the mice. The mice look perfectly normal, and we managed to target also particularly difficult site for treatment like kidney, for instance, or the choroid plexus. So this long road towards therapy, so the road has been long and tortuous, but important milestones were made throughout the years that eventually will lead to a successful therapy for this group of patients and potentially other adult conditions. So I thank you, all the people that contributed to this work, especially in the last 10, 15 years of my research. And of course, the collaborators, both within St. Jude and as well as throughout the United States and abroad, my funding as well, and now I pass very willingly my legacy and baton to two investigators, Dr. Sena Esteves and Gray Edwards at the University of Massachusetts Medical School, that are continuing the work on sialidosis and developing therapy for this disease. And of course, last but not least, I thank you and I am very grateful to patients and the patient population for their graciousness and their patience, and I encourage people to check the Cure Mucolipidosis website for more information about the disease and the patients. Thank you very much for your attention.
Now it's my pleasure to introduce the next speaker, Merve Emecen Sanli. She's also getting the Young Investigator Award. Merve is currently working as a senior researcher at the Gene Therapy Center at UT Southwestern Medical Center, and she will be presenting her work on mucopolysaccharidosis type C, gene replacement therapy with a self-complementary AAV HGS-NAT vector.
Hello. I would like to thank the organization committee first for giving us to share our work here. So today I'm going to talk about our MPS IIIC gene replacement therapy with AAV9 vector. I have no disclosures. So I would like to start with a brief background information about mucopolysaccharidosis. So mucopolysaccharidosis are a group of disease caused by enzyme deficiencies and lysosomal enzyme deficiencies, which are involved in degradation of some certain type of glucosaminonucleotides. And there are a lot of 12 types of mucopolysaccharidosis, and MPS III is one of them. And the glucosaminoglycan in here is heparan sulfate. This is MPS III has 4 subtypes based on different enzyme deficiencies. And this is MPS IIIC is one of them, and it is rare autosomal recessive lysosomal disorder due to heparan sulfate acetyl-CoA alpha glucosamine and acetyltransferase enzyme deficiency. It is encoded by HGS-NAT gene, and in the loss of this enzyme, the heparan sulfate cannot be degraded completely, and the partial degraded heparan sulfate accumulates across the body. But the clinical findings are actually caused by the involvement of central nervous system primarily. And when the heparan sulfate accumulates in the central nervous system, it causes impaired mitophagy and endocardial reticulum stress, and it also causes hyperactivation of microglia, and the other thing is synaptic vesicular trafficking. and also the axonal transportation. And these pathomechanisms leads to neuronal loss and neurodegeneration consequently. The incidence of the disease is estimated in 1 in 1 million live births. So this disease, patients usually develop by the age of 1 year normally, and the symptoms starts at between 2 to 6 years of age. And usually the first finding is speech delay, and it progresses cognitive decline over time and results in loss of previously acquired skills. And for psychiatric behavioral findings, they have hyperactivity in the first decade of life especially, but then they start to loss of the ambulation ability, and they have impulsivity, aggression, anxiety, and sleep disturbances are very prominent in the patients, and autism-like features are also very prominent, and this sometimes cause the misdiagnosis of patients. And over the time, when the disease progresses, patients have seizures, spasticity, ataxia, loss of ambulation, and in advanced stages. And the other findings are progressive hearing and vision loss. And in other type of mucopolysaccharidosis, when we compare with the other type of mucopolysaccharidosis, this disease has milder hepatosplenomegaly, coarse facial features, and joint findings. And the prognosis is not very bright because of the progressive neurodegeneration, patients' loss of the independence, and it causes early death, often in the second and third decades. So because this is a single gene disease and because there's no curative treatment, we hypothesize that the gene replacement therapy with AAV9 vector could ameliorate the disease findings. So for this aim, the NAKIN MPS IIIC mouse model was generated by Dr. Alex Bijetsky, and it was characterized by them in their team as well. And the AAV9 vector was generated by our vector core. For this disease, we generated AAV9 vector because AAV9 has a high tropism in central nervous system. And we use a self-complementary AAV9 because its transduction efficiency is much higher than single-stranded AAV9. We also use JET promoter. This is a relatively weaker promoter, and it is a ubiquitous promoter as well. We chose this one because we didn't want, we just wanted to protect avoid the toxicity. And the HGSN18 gene couldn't optimize to increase the transcription efficiency as well. So we chose the intrathecal route because the disease is mostly affecting the central nervous system. So we focused on treat the central nervous system findings. So we chose intrathecal route to administer the drug. For the safety study and efficacy studies are conducted in parallel. And for safety study, the wild type mice was dosed intrathecally with vehicle or a high dose at P7 to 10, postnatal age P7 to 10 days. And for efficacy study, the NAKIN mice were dosed with vehicle, low or high dose at either P7 to 10, which is an early treatment time, pre-symptomatic time, or P150, which is post-symptomatic time. So at the age of 8, then the mice, after the administration, the mice were starting to monitor. And at the age of post-injection, 8 months of post-injection, 5 mice in each group were euthanized to do the analysis of tissue enzyme activity and substrate accumulation. And the remaining mice were monitored until the age of 15 months, and they sacrificed for the AGS and AT mRNA expression and the organ weight analysis and for tissue toxicity evaluation. In the meantime, behavioral tests were performed at 4, 6, 9, and 12 months of age. We measured the motor and cognitive activity of the mice with this behavior test. We also collected the urine at 4, 6, 9, 12, and 15 months of age, and we did serum toxicity panel analysis. So these are the results of AGS and AT-mRNA expression at 15 months of age. And because this is a codon-optimized AGS and AT, it is not an endogenous or mRNA, we we do not see an expression in wild-type vehicle and knockin vehicle groups. However, the treated groups and in wild-type and knockin treated groups, we see the mRNA expression broadly in the different types of tissues, despite we only dosed the mice intrathecally. There's some leakage of the AAV9 in the systemic circulation. And in this graph, we see the vector biodistribution. So as it is, I can say again, in the wild type and knockin vehicle groups, there is no vector observed in the tissues. But in the treated ones, we can again see a broad vector biodistribution in different cell types, tissue types, and as well as in brain tissue. So we also measured the AGS and AT enzyme activity at 8 months of age in brain, spinal cord, and liver tissues. And we see here that in wild-type vehicle and wild-type high-dose group is significantly increased, and the knockin vehicle group is significantly decreased here. And there is a partially rescue in the treated ones. In spinal cord, the rescue is significant in high-dose group, and in liver, there is only a partially rescue in terms of AGS and activity with treatment at P7 to 10. So we also measured the urine volume of the mice, and in the left, we see that at 9 months of age, we see that the dramatic urine volume, urine retention in knockin vehicle groups, which is significantly increased compared to wild-type group. And there's a significant rescue, dose-dependent rescue in the dose-dependent, and actually also the treatment time-dependent rescue in the treated groups in both P7 to 10 and P150. And this is the 12 months of age, and the rescue in P150 in low-dose group is lost here, but the other groups still sustain the rescue in high dose and low dose at P7 to 10 and high dose in P150. And we, in terms of the survival rate, actually the knockin mice had to be euthanized due to extreme urinary retention over time. So we can say that treated MPS IIIC mice lived longer than untreated mice. We also measured the novel object recognition performance, which measures the memory function of the mice. And here on the left side, we see the results of early treatment cohorts, and on the right, late treatment cohorts. So at the age of 6 months, there is a reduced new novel object recognition performance in the vehicle group, which is partially rescued in the treated ones. And at 9 months of age, this rescue is significant in the low dose group. And in late treatment group, the rescue is significant both at 6 months and 9 months in low dose and high dose treated groups. So in body weight, we did not see any difference between the treated and non-treated groups in both males and females. And we did also serum toxicology panel analysis, and these are not affected with the treatment in MPS IIIC mice. So in summary, in terms of efficacy, we can say that dramatic and sustained increase in HSNAT mRNA expression at 15 months of age in mice treated P7-10 was observed. And reduced HSNAT enzyme activity at 8 months in MPS IIIC mice is partially rescued with the treatment at P7-10. Urine retention is also rescued with the treatment at both treatment groups, early and late treatment groups. And survival is improved in treated MPS IIIC mice because they don't have a urinary retention. And the reduced novel object recognition performance at 6 and 9 months of age in MPS IIIC mice is rescued with the treatment at early and late treatment cohorts. And in terms of safety, body weight and serum toxicology panel are not affected with the treatment with our vector. And so, in conclusion, we can say that these findings highlight the gene replacement therapy with our vector is a promising strategy for treating MPS IIIC mice. So the studies are still going on. We are still evaluating the postmortem histology and substrate heparan sulfate accumulation in tissues and urine. And we are also planning to start a GLP toxicology studies for further assessment of our vector in rats. And we are planning to advance the experimental therapy toward clinical application. Lastly, I would like to thank to our collaborators and thank you for your attention.
It's my pleasure to present the last speaker, Ryan Colburn from Los Angeles, California. He will be sharing his insights on patient preferences for gene therapy and future of funding and reimbursement of gene therapy for adult onset lysosomal storage disorders.
I guess I have to stay next to the mic. Can we make the notes bigger, please? Disclosures, learning objectives, all the fun stuff. I was asked to talk about the future of funding and reimbursement for gene therapy in adult onset lysosomal disorders. So this is what I came up with. It's got a bunch of other stuff sprinkled in there as well that I think is just really important to call attention to. So we start off with the commercial baseline of where we're at. And then the main thing to express here is that we have a lot of moving parts and contributors to the drug development machine. And we have this sort of wellness for people experiencing these disorders as our North Star and our focus, but there's no doubt that the way the machine works has some economic requirements and factors inside of that too. So in LSDs, ERT is a well-established strategy, and we know that there's a lot of interest in gene therapy strategies as well. And we have a range of costs for standard dose in adults and differences in access to treatments. So on the left side, we have the range of costs, and just to kind of give a little bit of a comparison, put it on a nominal 10-year projection. On the right side, we have how many people in the world have access to reimbursed treatments for each of those modalities. Relative cost parity, but with unfavorable financial fundamentals for gene therapy. There's a lot of front-loaded versus distributed costs, and there are some efforts and discussions around pricing models that might address that. But you're committed, from a payer perspective, you're committing spend that carries risk of not materializing from folks that would switch insurances or move to different places if there was death or advances in treatment involved, et cetera. It's just a tough financial hurdle to overcome, even though it has relative cost parity. And we see some of that is reflected in the amount of access there is around the world. Some of that's also a little bit unfair because of how long some of these ERTs have been around. But yeah, so that's our current landscape. We'll switch topics a little bit to epidemiology, or epi as the cool kids call it, because it's going to help us understand the rest of what we have to talk about. So why does epidemiology matter? It tells us about how many people are affected. It tells us how we're doing a diagnosis. It tells us what our strategies might be to study the disease and how we go about doing that. It helps us to motivate investment and interest into the space. It helps us to understand how we can get return on investment for our efforts, and then it supports the regulatory and payer discussions. So in general, it's fundamental for having a good strategy. And in the past, with rare, we've been told it's hard to do really anything that's a lot of data driven because it's rare. We don't have a lot of people. We have to work on limited information. And we had this idea that might not always be true, and we wanted to challenge that and break out of that box. So we took a look at, when we take a look at newborn screening, this is some of the stuff that's already in place for lysosomal storage disorders in the US. We can see that there's, in some conditions, quite a meaningful amount of data already starting to accumulate, with a lot of states having screened, and then even with current birth rates, no new adoption of newborn screening, millions of new data points added every year. So we can do something with that. So we did, and here's an example in Pompe disease. Now we have over 24 million babies that have been screened worldwide for Pompe, and we're at a rate of around 4.2 million new screens per year, or new babies screened per year. And we thought we could do a lot with that data. So a couple of years ago, when we were at about 16 million screened, we were able to get our hands on 12.6 million of those screens and the data from them across 35 programs in 9 countries and 4 continents. And this is a snapshot of what we saw and how we put together that data. So each blue dot on here is an individual jurisdiction, and historically you might have seen literature representing each of these individual jurisdictions independently. And we said, well, that's a little silly to us anyway. Heredity is a common process no matter what part of the world that you live in. Why are we looking at each of these as independent variables? So we put it into this binomial model that gave us the fidelity of the individual jurisdictions data, but then also put that together with heredity as a whole to look at all of the screens across the world. And so those blue dots are each individual one, and then the red is are these plus minus 3 sigma values, and for simplicity, we just need to know that those are proportional to the amount of uncertainty that we have in the data as we go along. And what we see is contrary to what the previous literature had suggested, that each of these individual jurisdictions had very different prevalences or incidences or whatever word they use for rates of disease. They don't actually. But as we add more data, we can see that 82% of all of these 12.6 million screens, the variability in that 82% of that variability is described by a single variable sample size. So we can't conclude with all of our data that there's any difference across regions, and in fact, there's strong suggestion that there is a global convergence. And so this is something new that we learned, and we can take that new data or that new learning and apply it to the world of Pompe. This one's a little bit boring, but just to kind of show for any of the nerds in the crowd, the math really supports it. One of the things that we think is important when you're doing these kinds of analyses is to go beyond just consideration of alpha error. Most of us will know that as confidence interval is 1 minus the accepted alpha error. And we add a power analysis to it as well. And we think that this gives us a far more honest look at uncertainty in it. The main thing to point your attention to is, so I guess describing the table a little bit, these are 4 different studies done over the last 20 years looking at Pompe epidemiology. And it's showing the relative statistical strength improvements that are possible with the large data sets enabled by newborn screening. And the main takeaway on the right side there is that those whiskers are the representation of uncertainty. Each one is paired with the left side of the individual point being just considering alpha error, and the right side considering beta error as well. And we can see why I like beta error, because it's a much more honest assessment of how uncertain we really are. And this newborn screening data-based approach gets us really to a relatively tight distribution, something that we can really use to go forward. So in summary, on the Pompe B side example, we're at 1 in 18,000, and that's a one-sided figure. It's probably going to move to 1 in 15, closer to 1 in 15 as we resolve a lot of uptick in VUS. And that means that 350,000 people in the world have Pompe, and we can be pretty sure of that. Very generous estimates would say that 10,000 have been diagnosed, and we have a little bit more reliable estimates that a little over 2,000 are on treatment. It also means that over 7,000 babies are born each year with Pompe. And this will all come back together to financial stuff in a minute here. So 220 of those 7,500, 220 of those babies will be diagnosed at birth and have the best possible outcomes for their health preserved. 220 of them will also get, another 220 of them will get diagnosed at some point later in life, maybe after quite a lot of damage has occurred. That's really something that's pretty scary to me. So all that points to that headwinds are coming. So improved diagnosis aligns with our North Star, but it also means that there's a lot more cost in the system to treat all of those people, certainly with current projections. So if we take a look at where we're at currently, in 2025, about $1.7 billion will have been spent globally to reimburse drug costs alone, not administration, not any other logistics, drug costs alone for Pompe disease. And 50% of that is spent in the US. So again, one of the themes of this whole talk is going to be the concerns about US centricity and the needs to focus globally, and how that's only going to get worse, and we need to stay more vigilant there. With newborn screening kicked off in the US and having large adoption, we're at 99% of births in the US occur in a place that has newborn screening for Pompe. We're going to add $165 million a year of revenue at current pricing structure, just based on new customers. That's the opportunity there. If we scale this out and said, well, to help the most number of people to the maximum amount of wellness, we want to diagnose more. So that would mean that there's up to a $266 billion market or demand for Pompe treatments at current cost, and that's a really big number, and it's not realistic. The good news is that even at a hypothetical 10 times cheaper and single dose, it's still a much bigger number than we're at today. So the business motives are still there. We just need to rethink how we go about developing drugs and pricing drugs and doing all that kind of stop thinking in our small pond and start thinking a little bit of a bigger pond. There's plenty of money to do it, just how that money gets spent. So realizing opportunity, sticking with our headwinds analog, we can change course a little bit and use some of those winds to our favor towards achieving our North Star of wellness. To talk about that for a second, I'm going to awkwardly shift to a sink. So imagine we have this sink, and this sink is, you guessed it, not a medical sink. It's just an analog for lysosomal storage disorders. So we have this sink that doesn't work properly, doesn't drain properly, and it starts to accumulate this stuff in there. And eventually it spills over onto the floor, and eventually that floor starts to accumulate some damage. And now we have this bigger problem. It seems pretty silly to call this plumbing problem a flooring problem, doesn't it? But that's what we do with a lot of lysosomal storage disorders. So we have this mental model for disease progression that overemphasizes symptoms. So everything that all of our historical basis for diagnosis, and we know that diagnosis is sort of where the rubber meets the road in terms of helping people and also realizing opportunity to fund ongoing development, to have participants in ongoing development, et cetera. So we have this language that we talk about that is really almost all symptom-based. And so one of the things I want to pause for at this meeting is I was really, really encouraged by some of the talks yesterday and some of the talks today already that we're returning back to the basics and the fundamentals of understanding the root causes of these disorders. We're looking at the cell. And so we know that these lysosomal disorders, they start out with a code disruption that creates a protein disruption that then causes disorder in the metabolic process that eventually causes disruption in that cellular process and accumulates into an organ level process, and then eventually symptoms. And so if we're only looking at the end of this, we're always going to be behind. And this bears out in our performance too. If we have an honest assessment of our performance, we would estimate that we're 0.6 to 3% good at diagnosing Pompe disease in that example, using our clinical symptom-driven model. Switching to alternate models, we can see that diagnosing with a screening process gets us upwards of 90% of process performance. So symptoms are a level of progression. They are a level of progression, but they're really just a proxy for the underlying disease. So we need to focus on the underlying disease to really make some progress in addressing those headwinds. One thing to highlight here, I often hear people talking about newborn screening as an example of population screening, that it identifies babies that might be at risk or may develop disease. And at least all of the current newborn screening that's in place is detecting right where that light bulb is. It's actually already detecting disruption in the metabolic process. It's not, if it was only sequencing, straight to sequencing, sure, we might not have that coupled pair of the actual disruption is already happening. But we're doing enzyme activity assays across the board in LSDs. We're already detecting disruption. We're already detecting dysfunction. So yeah. So how do we prepare for this future where if we've done a good job, where we want to do a better job of diagnosing, we want to do a better job of helping, we want to have the funding and the business case to have to be able to do the science and develop the therapeutics that help people. But we have this expense that payers are going to push back against. Well, we need to become undeniable. And so this is just a snapshot of some current vulnerabilities. When I think about what are the things that are going to get in the way, that are going to give anybody wanting to push back a chance to do so, that will prevent future study, future investment, adoption of gene therapies, et cetera, is we use language that allows things to go down the road. We keep using words like late or adult onset of disease, and it's not. It's maybe some later onset of symptoms, or recognition of symptoms, really, because symptoms are only things that I can realize and then decide to go to a doctor, and then we can look into. What you guys see as physicians or as researchers, those are all signs, symptoms. So we're using language that already does a disservice to the underlying mechanism of disease. We're describing our sink problem as a flooring problem. So we got to do better with that. I can't read my own notes. And then the at-risk of developing disease stuff. We also get stuck in this loop where we're referencing outdated literature. And I guess the comment there is, if you're not regularly reevaluating the new information that is coming out and using that to inform your opinion, you're not doing a service to get ahead on. We're just kind of holding on to these old things that are going to help payers push back on us. The symptom centricity. Not only does it do we need to work on guidelines that recognize progression earlier and then therefore unlock access to treatment earlier to maximize outcomes. We also need to recognize at a cellular level what the mechanisms of damage also decrease efficiency and maximum opportunity of the therapeutics that we're developing. None of these therapeutics, whether it's a gene therapy, enzyme replacement therapy, et cetera, will penetrate fibrotic tissue, make it past those barriers. It can have the perfect targeting receptor binding, doesn't do it. And then treatment challenges. So we've got this really long development process and low production scales. Again, we can use this updated epidemiology to help us think about very, very different economics on the industry side, on the production side, and how we go about development, and then burdensome logistics that keep some of these therapeutics from making it to lots of places in the world. So broadly, an encouragement that language matters. So be careful about how you use language. Take the papers, the literature, we generate the manuscripts that we put out are the foundation that future payers will use to either deny that disease is progressing or recognize that it is. So take it upon yourself in every manuscript that you write or that you read to think about how your language might be used against you later or used against progress. I think there's an opportunity to differentiate a threshold of detection and a threshold of action in disease, and the detection we obviously want to be as early and sensitive as possible. The action might be different, but some of these adult or late onset diseases might have a different course of action, a threshold of action, and that's something that we need to figure out how to do. And it might have different modalities associated with those different courses of action. Diagnosis, of course, matters. We need to continue to increase diagnosis. I'm really afraid if we take our foot off the pedal there, and slow down at all, we're not going to get screening, which is what we need for LSDs. We're not going to get screening elsewhere in the world. And starter treatment timing matters, and then geography should not matter. We need to be wary of all the U.S. centricity that we already have, and that's going to continue because we have better diagnosis here. And then these are just some closing thoughts of how each of us in our roles can help prepare for creating the change that we want to see to realize the opportunity afforded by the epi and the new treatment modalities development. Thank you.
So all speakers, please, on the stage, and then we will start the Q&A. I think it was a really excellent presentations. So Ryan is first. I want to ask a question. I completely agree that classifications of these disorders are problematic, and all disorders are continuum. And so, when we started newborn screening in Pennsylvania and, late onset Pompe patients, we started many patients on treatment in 6 months of life, and they are called late onset. It's not a late onset disease, right? So especially when we start newborn screening and detect these patients as early as possible, we know that many patients present early, but we are not able to make the diagnosis when they present. And Pompe is a very good example of that. But there are also challenges because newborn screening is detecting many patients with variants of unknown significance, and some of them have 2 VUSs, some 1 pathogenic, 1 VUS. We do follow them, but at the same time, it's possible that some of them will not have disease. So it is a challenge, and it's also a challenge because when there are VUSs, some physicians, some centers, and especially with that classification, and they tell patients that come back when you have symptoms or later when you're older. So those are, I think, challenges that we face. So I don't know do you have any insights on that?
Yeah, no doubt there are challenges, and I think Pompe ends up being a really good example because of how broad the spectrum is and sort of how early the adoption has been. So I think we have sort of a service to an opportunity to serve the broader LSD and rare community by studying Pompe and figuring some of these things out. There's been 2 studies that have done a systematic following of a cohort of newborn screened late onset genotype children. And each of those studies had about a quarter of them were homozygous for the IVS splice site variant, which is the most mild variant, and if you have that in homozygosity, you'd expect the most mild form of the disease. 100% of those kids in those in each of those two cohorts have detectable features of Pompe-specific features of progression. Is there sensitivity of action? Like if you start treatment for them at 6 months or 6 years, will it be a meaningful difference? Maybe not, but certainly it'll be better than waiting until they're 20 years or 30 years until they have trouble going upstairs or going through school and having urinary or bladder incontinence and having to deal with some of the social challenges there. I think symptoms are important. How the disease manifests is important, but for us on shaping the science and the early side of it all, that kind of needs to come to secondary in our disease understanding. We really need to swing the pendulum the other way to understanding actual progression before it gets to the point of a symptom.
By the way, please note that Alessandra is online and she can take questions as well. So do we get any questions from the floor?
I have a question actually for Dr. Dazzo. Obviously, there is cyanosis that proposes Hello? Sialidosis proposes actually significant challenges for therapeutic modalities, including gene therapy. So basically of this triple interaction with the neuraminidase and the PCCP, is that right? And the beta-gal. So in the ideal world, how would you design a gene therapy product? Like, is it triple vector to have all these 3 genes interacting together, or CRISPR and another modality? So, like, if everything works, obviously.
Hello?
Yes.
Can you hear me?
We hear you.
Okay. Well, thank you for this question. Of course, the effect that neuraminidase, first of all, I'd like to actually compliment the euthanizer for this very insightful one process the salicylic acid on PPCA, for instance. So what we have seen also is the awkward phenomenon that in absence of U1, PPCA progressively, at least in the context of some of the mutations, which is also complicating the picture because in different mutations the behavior might be slightly different, or the protein might be slightly different. So the fact that U1, we tend always to think about U1 in the context of its association with PPCA in one direction. But it's important to keep in mind that PPCA is a natural substrate of U1, and processing of the salicylic acid of PPCA in absence of U1 does not occur, and the protein becomes hyperactive. So you might have the additional complication of an hyperactive cathepsin A activity in cells of different organs. So maybe the approach of so one important lesson is to keep in mind that the enzyme is not alone, but in combination with other two, and works in combination with other two. And the second important thing is that there be a therapy that addresses and monitor the activity of all three enzymes, or improve the activity not only of U1 but also the other two enzymes in combination with U1 is important to address or focus on.
Thank you. More questions from the floor?
I have one question to Merve. So you are doing intrathecal, right, IT? Have you considered also trying intracisternal or intraventricular? Because the reason I am asking is that the study is done on MPS 1 and MPS 2 and AAV9 gene therapies, and intrathecal didn't really show it showed less efficacy than intracisternal or intraventricular. So would you consider doing, different type of administration?
Yeah, this is a great question, and we always consider the route of this administration. But this is because this mucopolysaccharidosis type 3C, it is a generalized brain disease. It's not a specific region involvement in the brain. So this is one of the thing, and the other thing is intrathecal administration is much easier than the other ones, especially the intercisternal magna is very hard to do. And our laboratory is specifically expertized in this one, intrathecal therapy actually. And because it is a generalized brain disease, not for specific regions, we chose to use intrathecal therapy. But yeah, they could be done, and in different administration routes can be done, of course, to see the difference between the efficacy.
I have an additional question about your therapy. This is a membrane protein, huh? But nevertheless, looks like even expressing, it doesn't matter membrane or not, looks like. Is that correct? Because membrane protein must be localized to lysosomal membrane. But this gene expression looks like it does not matter to localize into membrane.
We did not check this actually histologically and molecular level, but this is not a secreted protein, but the membrane protein, yeah.
Yeah, but you are expressing by AAV, then it's not localized into membrane. How it works, which we don't know. I'm talking about the mechanism. Mm-hmm. Result is fine, I understood. Mm-hmm. But mechanistically must be localized into membrane. That's our common sense. But looks like it may not. Then it's interesting as a scientifically.
Yeah, we did not check this actually, but we just checked the behavioral test and the, the other tests like serum mRNA expression levels and enzyme the analysis, the residual enzyme activity, and it looks like it is effective somehow. But in molecular level, we did not check this one.
Yeah. Okay. That's another question is that why are you using a knock-in, not a knockout?
It depends on we don't have a preference to use a knock-in or knockout models, but our collaborators, because they generated a knock-in mouse model, we use knock-in mouse model in this disease. But we have other types of diseases. We are doing the study in knock-in models with knockout models to see the difference, but we don't have a preference actually. The collaborators just generated a knock-in mouse model, so that's why we used it.
Other thing with MPS III is that it's quite challenging to find patients. It is ultra rare. It's more common, I think, in the Middle East, so we hardly see any patients here, and it's very difficult to make diagnosis. And most of the time they present, early, but we diagnose them after 6-7 years of age.
That's right, because the symptoms, because this MPS type is milder in facial, the coarse facial features, and the most prominent thing is, I think, the autism spectrum features, and they are misdiagnosed with this disease, and just maybe because of some molecular techniques are very limited in most of the countries, because otherwise, if we don't do the genetic analysis in autism spectrum disease patients, we cannot diagnose them, and they are just diagnosed with autism spectrum disease. So because they don't have very strong somatic manifestations, it is really hard to diagnose them if we don't have the molecular techniques to diagnose them.
Merve, that's for type 3C, actually they do have significant retinal degeneration when you compare with the other types of Sanfilippo, so they become blind actually. So does your, in the mouse, I think there is a retinal phenotype too. Did you look at the eyes? Were there any differences after gene therapy? You just report some behavioral changes, but is there any other thing that we can put our hands on?
Yeah, actually one of our collaborators, we just collected the eye tissues for them and sent them to analyze them, and so they will do it.
And I just want to comment how easy it is to fall back into discussing symptoms and the challenges of diagnosing something if you only wait for symptoms.
The challenges, we are running a small trial for MPS III, and that are, this is the patients we have is like all attenuated cases so far. They are adults, but they are very much impacted, and they start the journey around age 4-5. Obviously that they are impacted from the very get-go. So that is the whole thing. We should not be calling them adult onset or whatever, that is a wrong nosology. And similarly, like sialidosis, we do follow 2 patients with sialidosis, actually they're siblings. And it is called, the attenuated adult onset, but she's very much impacted. She has severe myoclonus, is a college student. Otherwise, she can actually, that's her cognition is intact. But myoclonus and severe seizures actually, that's impedes her from, any daily activity. And it's a sad disorder because she's much very aware what is going on.
And so it's the opportunity to start working on our language now so that as treatments come and we start to put indications together.
I think with the newborn screening, obviously John is much involved than I do. I am just a spectator here. I think we need to change how medical establishment actually thinks about diseases. And we are geneticists, so the culprit actually is the genes, is that right, and the protein products. So we should not be calling them. It's like Dr. Alpan presented is everything we're doing currently is a Band-Aid approach here. And then it's too much that we're just missing the train, for possible treatments for these individuals. But the issue is, to convince the physicians who take care of these patients, like I have, seen many, many patients with so-called LLPD. First, it needs to be changed, okay? So is that if a disorder starts at age 1, it is not called late onset. It has been started much earlier, but, by nosology, anything after age 1 is called late onset, which is a travesty. And second is you have actual high CKs in this patient. So basically there is a muscle, that's muscles are being destructed, and it has started a while ago. So what are you expecting to, the patients become very disabled? And this is what I'm seeing in other countries too, is, like from Netherlands. The patients come with significant impairment, and they're still deciding whether they should start the treatment or not. Maybe not, actually. You know what? If you are progressed that much, how much we can salvage with the therapies that is available right now.
Early diagnosis is very important. So it's very difficult to change, I think, those classification systems. I think it's important to keep on writing that disorders are a continuum, and then you will fall into somewhere in that spectrum. But people love it.
ICD-10, we have a single diagnosis for each of these conditions. There's not differentiated diagnoses. So there's something about planting seeds that we can do in each of our work and literature to start already changing it, because we're the ones that make the rules. Why do we have to follow something else? Lay the groundwork so that when conditions do come around and when payers do want to push back because, there isn't this severe disability, well, no, we want to start treatment so that we don't have to get to that point, and also that the treatments are going to work better that way as well. So we can start changing our language already. There's nothing that stops us from doing that.
Yeah, completely agree. Any other questions?
I guess we are...
The time, I think we have six more minutes. So I would like to ask, you are more patient advocate type thing, and then you guys are doing AAV. So how we can recruit patients for lysosomal storage disorders? If there are treatments available and the gene therapy in the clinical research, what do you think, how we can recruit those patients to gene therapy trials if there are other treatments are available?
If we focus on diagnosing, we have no shortage of recruitment problems. We have no recruitment problems. Everything. So I focus on central things not because of I'm limited to those. It's because thinking broadly and where are the nodes that we can press to affect change the most. Diagnosis is one of them, and then language is another one.
And one of the challenges also when you say diagnosis, for example, MPS III ABCD, right? And then when there is no treatment available, then early diagnosis becomes an issue. So enzyme test is available, MPS III ABCD, all of them can be easily detected through newborn screening, but you cannot do it because there's no treatment available. So it is kind of catch-22. So Yeah,
so you have to look at creative strategies where there's maybe opt-in opportunities for pilots or for more commercial programs and those kinds of things. And this is where, we call on who has the interest in that, the commercial interests in that coming to reality, and maybe they can participate and we can reevaluate our models now that we have updated epidemiology. One of the things that I didn't mention is we have those list of lysosomals that for which there is already some newborn screening. As we accumulate more, an increased sample size on each of those, I think that there's a mechanism for us to unlock improved epidemiology for conditions that are not newborn screened, so we can see where are the numbers that we expect to get using publicly available genomic data sets like NOMAD or something like that, that are also growing. And we can there'll be some more uncertainty to it, but we can at least quantify that uncertainty and be responsible about how we're making our projections and assumptions going forward.
Also, the newborn screening for diseases without treatment is so important to prevent the birth of another affected member in the family, which we all know so frequently. So I think newborn.
There's old school newborn screening where you have your first child, then you find out, and then you know to look for the second child. And that's a very heartbreaking way to do it.
Well, I think newborn screening eventually is the way to overcome the problem of the broad problem of rare genetic diseases that are all characterized by poor awareness. And no matter how many activities are there, publications, meetings, you always have this undiagnosed case that could have been diagnosed. And newborn screening, once organized well, and we have here the expert, is going to solve at least part of the challenges.